Welcome to the patio where we parlay. Welcome to Patio Parle. I'm so excited to have you guys here. Today we have Dr. Tranise Goodlow and Dr. Nathan Lott. We're going to be talking about healthcare, disparities in healthcare, inequalities, COVID, and of course the vaccine. But before we get started, I wanted to give you guys a little bit of an opportunity to tell us a little bit about yourself. So can we start with you, Dr. Lott?
Sure. My name is Dr. Nathan Lott. I am a pulmonary critical care physician currently practicing in Waco, Texas. I work for the Baylor Scott and White Health System, trained in internal medicine, pulmonary and critical care in Columbus, Ohio, and then decided to come home, where Texas has welcomed me back.
Yes, and we're glad to have you back. Okay, Dr. Goodlow?
Hi there, I'm Tranise Goodlow. I currently work full-time as a cardiology nurse practitioner in a private practice in Arlington. And I also teach adjunctly at a university. I teach in the grad school program for family nurse practitioner. And then I'm about to launch my own coaching business in about 2 weeks. That's coaching nurse practitioners on different topics that we may not have gotten enough of in school and to build confidence and knowledge.
Cool. I am so glad you mentioned that because I'm excited for you. I'm excited for everybody that's out here to really just jumping into what they want to jump into. It's been said that where you live dictates whether or not you live or die more so than your family history. Is there any truth to that? Can one of you all talk about that?
There is some truth to that. Statistically, just kind of big picture, people who live in lower socioeconomically advantaged areas tend to have lower survival rates than those who live in higher socioeconomic states. People who live closer to power lines or power stations or train tracks also tend to have higher incidences of some types of cancers, which will at some point impact survivability as well. So is there some truth to that? Yes.
Okay. Do you have anything to add to it?
I agree with what he has to say. Also, what I would add is, from a socioeconomic standpoint, one piece that I feel is forgotten sometimes is education. Because when you talk about education, that breeds more opportunity for you to live in a nicer environment, have access to care, and all of that. And there are huge socioeconomic disparities when we talk about white men compared to white women, and particularly minorities compared to white men. White women only make about 78 cents per dollar of a white man, and women of color, specifically blacks, only make about 63 cents per dollar of a white man. So when you look at it from that perspective, you're having less access to health care, which impacts outcomes, which can have detrimental consequences. Absolutely.
Okay. Can we talk about some of those are alarming statistics, by the way. I mean, wow. Can we talk about some of the personal experiences you guys have had or you've seen with implicit bias or disparities in healthcare? Is there anything personal that you guys can talk about?
I'll say from a personal perspective, there are some alarming statistics when we talk about the African American woman and bad outcomes in childbirth, right? Black women are 2 to 3 more times likely to die in childbirth. And conversely, black children are more likely to survive when they are cared for by a black physician versus a non-black physician. And those statistics are scary. Personally, that's why I opted to find a provider of color for myself and my children in my childbearing situation, because I know the statistics, and it's quite alarming.
Yeah.
So,
why do you think that is with the birth rate? The numbers you just gave for black women.
It kind of echoes what you initially talked about with the base of the question, which is implicit bias. There was also another study. I'm full of statistics today.
I love it.
There was a study done. The source is escaping me right now, but it was in 2020, and they surveyed 220 medical students and residents, and about a third of them literally said that black skin is thicker than white, meaning that they are less likely to prescribe pain medicine because of this falsity. Because I mean, it's simply not true. So when you think of things like that, and we have data that supports that, and then when you're conversely having a child, and if you're saying, I'm not feeling a certain way, or I am feeling a certain way, but because of the way you look, it's viewed, well, you can take it. So people don't listen.
Serena Williams, the comedian Wanda Sykes have all, voiced their experiences within the healthcare system and how their care teams may have not been as responsive to their complaints. And there is implicit bias in whether or not you take the complaints of a person into context when you are looking at the disease processes that form the differential diagnosis. So it's, and I won't say understood, but a more recognized issue that some clinicians are cognizant of in trying to step back from their personal bias and trying to evaluate the patient. And there are clinicians that just don't see it. And that's true in not just in medicine, but in a lot of different aspects. Specifically speaking on medicine, though, that bias can contribute to why the health of African Americans tends to be worse than those of their white counterparts. Black men are 2 to 2.5 times more likely to have issues with cardiac disease, diabetes, strokes, complications from diabetes, and a lot of that may be secondary to a misunderstanding of the significance of certain abnormalities that can be found on your general physical exam and or lab testing when you're seeing them in the office. So awareness of the bias is one way to help try to not ignore it, but to push it to the side and then look at the person holistically as you're supposed to as a provider.
But to counter that, though, you have to acknowledge that there's a problem.
Exactly.
And so if I don't feel like I'm biased, even if I am, I don't see a problem, so I don't have that reflective capability.
Which steps back to what I stated, that you have to be aware. Because if you're unaware, you're never going to know that there is bias. So there are clinicians, and I would say that a lot of the younger providers that are coming up that have gone through this whole process where they have more blended families, where they're realizing, equality has not been met in our medical field. And they're aware of the fact that equality is not meted equally amongst the different processes and patient populations. And because of that knowledge, they're able to more aggressively work towards that equality that we all, are truly seeking. But I feel that just like in general society, it's going to take a younger generation to help bring some of that to the forefront, because some of the elder physicians or clinicians aren't aware. There are many that are, but there are also many that are just not aware, and it's because that's the time in which they grew, and they're focused. They've got a wall, sometimes not intentionally, but that's just their training, where they feel like they're being open and inclusive when in fact they may not see it.
So are we making progress when it comes to the disparities?
I do feel that there has been progress. Is it where we want it to be? No. But movement has occurred. And that, I think, is a metric to look towards. Like the field of medicine is always in motion, and the field of medicine continues to grow. We're never going to reach 100%, but that is the strive. That is what we're aiming towards. We're always striving for the highest.
Okay. So those heavy numbers you dropped with African Americans, let's kind of move it towards COVID then. How has COVID affected us, the African American community?
If you refer to the CDC's report most recently, blacks are 2 to 3 times more likely to die from COVID. And again, some people have this misconception that, blacks are more likely to die from childbirth and die of COVID and all of these things because there's a genetic component to it, which is a huge falsity. These are about healthcare biases, implicit biases, and health disparities. That is why we are at higher risk. If you look at the history of medicine and the trajectory in which it was in its inception to currently, we have been mistreated markedly. One thing I wanted to point out was a physician who's credited as being the father of gynecology, which is laughable. James Sims, if I'm remembering his name correctly. He was someone who took enslaved African women, and this was back in the late 1800s. Took enslaved African women and experimented on them, no anesthesia, developed his processes or whatever you want to call it, and then to give him this title of being the father of gynecology is not only laughable, but it's absurd. So that sort of thing gets you angry, right? That sort of thing that's the history, and some people don't want to talk about the history. And then conversely, you say, oh, well, blacks don't trust. Why isn't the conversation not, what can we do to earn back the trust? Right. Because it happened to us, right? We didn't not trust because we didn't not trust for an unvalid reason. Right. And that's what's really the most frustrating part, and the interesting juxtaposition as myself being a provider, but yet I'm still a black woman in this world. Right. So.
That's good stuff. Anything to add to that, Dr. Lott?
As a process, COVID certainly has I'd say an unequal representation amongst underrepresented minorities. This includes African Americans, it includes Hispanics, and it's, in my experience, I'd say that it's not necessarily, I don't feel that there's just a genetic predisposition that makes one population group more likely to succumb to the effects of the disease. But I believe that there's a multifactorial reason for that. Part of the reason I feel is lack of adequate and early access to care. Earlier on in the state of this pandemic, you had, particularly in our area, there were a large Hispanic population that was hospitalized and suffering from the ill effects of the virus and the mortality associated with it. Culturally, Hispanic individuals tend to have, larger multifamily homes. So you have multi-generational homes where your abuela, abuelo, your parents, children, grandchildren, all in a single home. You have one person that comes in sick, and then with that close proximity, you have a significant ability to pass or spread the disease from one person to an entire household. And when the spread occurs, as we knew back then, risk factors, elder age, comorbidities. Hispanics also have a high likelihood of diabetes, high blood pressure, and succumbing or dying from complications of those disease processes that occurred as well. So those are some of the risk factors that contributed, I think, to the excessive mortality at that time frame. Consequently, or alternatively, in African Americans, at the very outset of this disease outbreak, you had people running around saying, oh, African Americans are immune to COVID vaccine. So, don't worry about it. We'll live, white people will die, yada, yada, yada. And where that came from, I don't know. It's the same argument that I have, or that people have been saying for children, and why children don't need vaccines, or why children, should be able to do things. Oh, children aren't impacted or affected by the disease at all. It's not like the virus is age specific. It has no genetic thing that looks at a person's age and says, oh, this person's under this age range. We're going to ignore them. We're just going to infect these people. No, that's not how viruses work. So there are a lot of misconceptions as to who was susceptible to the disease at the outset. And there's nothing that I've seen that, can say, these people don't need to worry about the disease. These people need to worry about it. Are there comorbidities that increase or tend to have a higher likelihood or risk of complications? Sure. High blood pressure, obesity. These are some of the standard risk factors for poor complications from the disease process. But I've seen younger patients that have no other health issues that have died from COVID. It's not just related to the people that have high risk. And the reason that I bring that up, and I think it's important for people to understand, when we report these things on a global scale, the risk factors are collated from all of the individuals that are infected that have died. So we're giving a macro understanding of what we're seeing. So if I have 1 million people that died from the disease and 500,000 are obese, okay, obesity is a risk factor. Of those that died, 250,000 also had high blood pressure. Okay, obesity, hypertension. But that omits the other 1.75 or 1.5 million patients that have other risk factors and things that are also included in there that increase their risk. So the big picture risk factors are exactly that, for us to say, hey, if you have these risk factors, you certainly want to be very, very cognizant about your lifestyle choices and the things that you do to prevent your risk. But just because you don't have those risk factors does not mean you can't get the infection and die from it.
Right. Okay. And not only that, but you have to look at the perspective of personal accountability and your responsibility to not only your family, but society. I think that we live too much in an individualized society where, again, me, I don't have COVID, I'm good, I don't care about you. And we're not going to be able to be successful with that type of mentality. Particularly as a healthcare provider, I'm passionate about it because I've made a career of helping. That's what my whole career about is helping. It's not about me, it's about my patients. So what can I do to give them the best chance at success? And to see people saying, well, I don't want to wear a mask, or I'm not going to get vaccinated because I don't like shots. That's not a legitimate reason to absolve you from personal accountability.
Right. You sound very passionate about it, and I kind of wanted to go into how, as healthcare providers, how has COVID affected you guys personally? Just at work and even at home, how has it affected you over the last year and a half or so?
When things first started, of course, everybody was scattered, right? What is this? This is new. How are we going to get over this? What's the new normal? That sort of thing. Things kind of settled out. And again, I'm in cardiology, so I mean, Dr. Lott here, he really was in the thick of the situation more so than me. But I can say in clinic, what was frustrating is fighting people to wear masks. And I will say as a healthcare provider that my job is to help you, and I care about you. But if you can't wear a mask for me, it's really disheartening. It really is, because it comes to a point where you want my help, you want my knowledge, you need me to guide you through certain things, but you can't respect my personal space or my health or my family or what I have going on. I always tell people it's not about, oh, I'm wearing a mask because I'm scared or this, that, and the other. I don't know who I come in contact with. I am not going to be responsible for spreading something to someone who's immunocompromised with HIV or cancer or whatever their family has going on. So we have to take the me and change it to we. What can we do to settle this thing down so we're not putting other people at risk?
Right. Okay. Dr. Lott, how has it affected you personally?
So It's been a rough year. I'm a pulmonologist. For those unaware, pulmonology is the field of lung disease. I am a physician who is certified in the management of lung disorders. I deal with asthma, I deal with COPD, I do a lot of diagnosis and management for lung cancers, and I'm a critical care or an intensivist. I specialize in the management of acute medical illnesses requiring intensive care unit care. Very high-paced, very cognitive, thinking a lot, and dealing with managing diseases that impact not just one not just one organ system. I deal with lung disease, I deal with kidney disease, liver disease, strokes, heart attacks. All of these things are part and parcel of the care that I provide. And I've been in practice since 2011. I finished residency, did pulmonary critical care fellowship. I've been in practice for a decent amount of time. I've dealt with the H1N1 scare back in 2009. I've dealt with patients with that and different disease processes in that time frame. And I can say without a doubt that this has been the hardest time that I've ever had as a physician in practice. I won't call myself the world's smartest individual, because I'm not. I feel like I'm good. I'm very good at what I do. I know what I know, and I have no qualms about my capabilities and what I can do. And this is one of those things that, in spite of all of the knowledge, all of the training, everything that I do, there's some things I just couldn't treat. And I can be as aggressive as I could. I've put chest tubes in, we've done central lines, arterial lines, proning, all of the stuff that needs to be done for management of these acutely ill individuals. And in some cases, in spite of all that, they still died. And I don't take it personally, but it's difficult to deal with that much death from a professional standpoint, because I'm in this business to help. I'm in this business to help people survive. I do what I do to see the improvement. I love it when people that I've taken care of come back after their hospitalization and say, "Thank you, Doc. I'm glad that you were there to take care of me." And there's been far less of that during this than the entire time that I've been in training and in practice. And that has been the most disheartening part. Truly, depression, hit, because, like I said, I didn't know what to do. I did everything I could. I did everything right. I did everything that was considered medically appropriate. Now, there are some things that people have done and recommended that there has been no evidence at the time of recommendation, and even after studies have been done to show that they did not impact or have any role in the therapy, that I refused to do because I knew they wouldn't work. And still, it didn't help. So yes, depression was certainly one of the things that I had to fight with. Did it have an impact? Yeah, I would say it did. Didn't impact the medical care that I provided, but it certainly had its impact on me and my family. My children were aware, of the psychological stress that I was going through. My wife was aware of the psychological stress that I was going through, and it took time, therapy, and some help. Fortunately, I can say that, things are starting to improve. And a lot of that, I feel, is secondary to the vaccine. And had it not been for the vaccine, I feel that at this time, not only would our hospital, but I believe the entire health system across the country would have been overwhelmed. There are a lot of people that have been railing against mask wearing, have been railing against doing, physical and social distancing because, oh, how can you take away my freedom? Oh, how can you do this? Oh, how can you do that? But they don't recognize that had we not done that a year ago,
Right. Where would we be now?
by Labor Day of last year, had we not done that, you would have had a lot higher death rate than we have right now. We've got 500 over 500,000 have died from COVID to date in the United States of America. It would have easily been twice that, and I honestly know that we do not have an accurate count of the number of deaths related to COVID. And it's not one of those things where I'm sure there are you conspiracy theorists watching this right now that are going to say, oh, you're just doing this because you're going to get paid to, fill out the death certificate. I don't get a red nickel. I don't get shit for filling out a death certificate. That is my obligation as a physician, to make sure that the appropriate information is reported. So those of you that think that this is all for business, I can tell you you're wrong. I realize I can't convince you, because obviously you're at that point now where you're going to believe whatever you want to believe, and the truth is just not something you're interested in hearing. But the reality is, we would be a lot worse off now had none of those things been done. And it's not a fact. It's not a matter of, of just why they died. The deaths come because at one point, let me step back. Let's just do a numbers thing. Okay, I live in Waco. I live in Waco, Texas, where let's say the population is, let's just say 300,000. I'm just going to shoot for a round number. They say that, the percentage of patients with COVID who develop who develop disease that requires hospitalization, let's just say that's 1%. Let's just say 1%. That takes us down to what? If it goes from 300,000, 1% of 300,000 is 3,000 people. So let's say 1% of people with COVID that are hospitalized develop severe COVID that requires an ICU level of care and or ventilation. So 1% of 3,000 is 300. The city of Waco does not have 300 critical care beds to manage that many people that are going to need ventilators. The entire United States of America is a population of what? 352 million? Right? Yeah, give or take.
Right.
Give or take. 1% of 1% of 352 million outstripped the ventilator capacity of the country, outstripped the ICU beds available to manage that severe number of illnesses. And nursing, ancillary staff as far as respiratory therapists to help manage the vents, critical care certified, or even hospitalists that have critical care certification and are available, are still outstripped by the numbers. And if we had done nothing, and say, let's just live life the way that we've been living it, I don't care, we would have, as a country, rapidly run out of space, and then we would have been at a time where we had to kind of ration care and say, who are we going to put on the ventilator? Are we going to put Granny, who's 72 years old, on the ventilator, or are we just going to let her die so that, Biff, who chose not to do any of his social things, had a huge party and spread it to, 80 of his closest friends, and put him on the vent so that he can live? No one wants to talk about,
Absolutely
being
not.
Accountable
Right.
for that decision. And I promise, if we had gotten to the point where we had to ration, someone would complain, well, why did you choose this person over this person? Well, if you'd have done your part and helped us to prevent the spread, we wouldn't have had to.
Right.
But hey.
So basically, the social distancing work, the mask work, and the vaccine is working.
All three. I'd say prior to the vaccine, social distancing and mask wearing were they were the only things you really could do.
Right.
Mask wearing has been a very useful component, because think about other cultures. China, Japan, come flu season, they're masked up.
Right.
Why?
Right.
Because they value their society.
Right.
They value their culture. Their elderly are actually important to them. And because of that, they want to try to minimize and limit the spread from them to their elderly population. So
I guess that really says a lot more about America than
And that goes back to my original point about this me mentality. I don't want to wear a mask. I'm uncomfortable. I don't want. It's not about you. And like I said, we're both in healthcare. We've both made careers of helping people. So you don't have this tunnel vision.
Right.
You see the bigger picture. Like, this is what we got to do to get out of this.
Yeah.
You know, there are people are traveling away from their families, risking health. Being a healthcare provider, you're risking getting COVID just being there.
Yeah.
You know. So it's frustrating when you have that patient that wants to fight you, and it's like, God, just please,
It's just a mask.
right. It's not a big deal.
June 4th, Governor Abbott has lifted all mandates. How do y'all feel about that? Schools?
I feel that as
Strongly, apparently.
very.
Okay.
I don't feel that it makes any sense at all. It obviously means he has no grasp of public health. None. Absolutely zero. And whoever's advising him obviously has no grasp of public health either. This makes absolutely no sense
It actually makes
at
sense
this
to me.
currently stage.
It makes sense to me.
From a public health standpoint. Now, I can understand from a money standpoint
Right,
why
that's what they're
he's
doing,
doing
right.
this. And that is the only rational
Logical explanation.
conclusion
Right.
that I can come with as to why he's doing it the way he does. And it's interesting because he's negating the ability of local areas to do what's best for their people. The fact that he's making it a governor's mandate, no, we can't do it, says more about his desire to exhibit control over those that would not agree with his mindset, because every location has a different risk profile. There are some places that are much higher risk,
Right.
and mask mandates may be more beneficial to help enforce the public health and enforce the public good. But again, this isn't about that. This is about showing, hey, I have my donors and they want me to do this. I want to continue to do what I'm doing. So he wants to do it that way because it benefits him and is not in the interest of the people of this great state of Texas.
Well, when you speak from an economic standpoint, which really doesn't make sense. So if you go back to last summer when they were talking about we're going to help out the businesses, right? We're going to give money so that businesses won't go crashing and everything. This statistic, make sure I'm not misquoting the statistic, over 90% of either minority businesses or female businesses did not get any help. So who's the money's going to?
We know who it's not going to.
Well, correct. So when you say we have to open to help the economy, no, the same people that are benefiting will continue to benefit. And if you're benefiting on death, you're not in the right business.
Right.
And it's a morality thing and it's a hard thing. And I question it.
Let's not go on the morality issue of it. I mean, if we're really going on morality here, I think that's a different conversation.
That is a different conversation. But in America, all leads roll back to money.
Everything goes back to the money.
So that's the answer for everything. And, it's funny. They say, well, we need to open up the economy because, we need jobs and we need X, Y, and Z. Well, if everyone's dead.
The economy never closed.
Well,
the economy never closed.
That's also true.
No, and there are certain aspects of the economy that actually expanded significantly.
Yes.
Even during the pandemic,
Yes.
that have expanded
Yes.
significantly. So no, the economy is never really an issue. Not as much as I think they want to meet. Did stocks and everything drop during?
Yes.
Of course.
Yes.
Expectedly. Hell. That happens.
Right.
But anyone that follows stocks and the stock market and all that stuff, it's a cycle. You're going to have ups. You're going to have downs.
Right.
All you have to do is hold out. Eventually it would recover. But we as a people, not just black, but a country, I think are sometimes not attuned to the fact that, these things happen. Okay? And it's not a question of if It's a question of when. It's going to.
And
So
to throw a monkey wrench into what you're saying, because this is America, right? Isn't this a Christian-based country?
depends on your it depends on your perspective. It's Christian for some things and not so Christian for others.
Correct. But, we have Christ on our money, amongst other things. But the point being is, if America is supposedly Christian, okay, what about this helping others? What about this less selfish? I'm just saying what the country claims to be Christian. I'm just saying what the country says, right? But this, I want this. I want to do that. It's frustrating. It's incredibly frustrating.
I get you.
This is America. So one of the things that we really we were on mask. As for you and your household, will you continue wearing masks? And
Hell to the yeah. I don't trust people.
At school, your kids.
My children will wear their masks
Absolutely.
in class until vaccinations have been rolled out to all age groups. And I can feel confident and comfortable that more of the students have been vaccinated.
Right.
True. Do children have less risk of developing severe COVID that would kill them? Certainly. But they can still get it.
And some have died. Some children have died of
Children
COVID.
have died from it. But the other part of it is they have grandparents.
Right.
Do you want your child to be the one who kills your
Right.
Nana or your papa?
Right.
So I'm kind of
Especially if you're not vaccinated.
Right.
Or they're, and yeah.
That's what I was going into.
And so much so with my children, I have very young children. And so I'm vaccinated. My husband is vaccinated. We wear the mask. We're mask wearers anyway. But we make it a point to wear it to role model good behavior. You can't expect your children to be great and do the right thing if you're not doing the right thing. So it's vitally important that you role model good behavior.
I agree. Ideally, you all would have had some people who are against the vaccine sitting here talking to you so we could kind of weigh in on the risk and the myths. We're winding it up here, but I just want to go over one of the myths that I saw, or one of the memes. I'm assuming it's a myth because it said, "I have an immune system. I am fully vaccinated." Is that just true? Where did that come from? Why would anyone believe that?
Well, to add some levity to the situation, in the Middle Ages, people had an immune system as well. Many succumbed to the bubonic plague. Over 500,000. Actually, I take that back. There's a couple of million that perished from the bubonic plague. You have an intact immune system, and people die from the flu. They die from pneumonia every year. These people all have an intact immune system. The difference between those infections and COVID is that in general, most of those infections, we at least have had exposure to. Mm-hmm. The COVID-19, true. If you've looked anywhere online, they'll tell you, humans, we've all been exposed to coronavirus. And that is very true. We have been. Coronavirus does not just infect humans, though. The viruses that infect species are typically disease specifics, meaning that they cause illness in the species in which they're accustomed to. In general, these viruses don't cross. However, in immunology, there's a term, antigenic shifting, where an antigen in the envelope or the disease shifts from one species and shifts to another. And that's when a virus or that infects one species can then become able to infect another species. And that was the cause of the swine flu. That was the cause of the 1918 Spanish flu and any number of these SARS, MARS infections that have occurred over time. This shifting is a known microbiological process. It happens. But the problem is when that shift occurs, our human immune system has no exposure to it. And without that exposure, you can't generate a good immune response because your body has never seen it before. And because of that, when you do get the infection, the recovery or response can be significant, particularly in those that are predisposed to developing it. And how do we know who's predisposed? There's no way to know. Right. It's impossible to tell because no one's been exposed to it before. In the entire evolution of humanity, no one's been exposed to it before. So, yeah, you have an immune system. Will it try to generate a response? Yes. Are there some people that can generate a response and have a good response to it? Yeah, I'm sure it can happen. But there's also a much higher likelihood that your response to it is not going to be as significant or effective enough to help you live through it. And that's what we've seen in this COVID pandemic is the individuals who weren't able to generate a good response that survived and lived it.
And to add to what you're saying, patients come in the office all the time ask us, and of course we're cardiology, well, should we get the vaccine? Well, I tell, should I get the vaccine? And I tell people all the time, the real question is, do you think you'll survive? I mean, I'm not talking about a responsibility because as far as public health is concerned, you should get the vaccine. Okay, that's quite clear. But if we're in this me mentality and me thinking about myself, the question is, if I get COVID, will I survive? And that goes back to some of the points that Dr. Lott was saying earlier. The obesity, the diabetes, if you have underlying pulmonary condition, you're less likely to do well getting COVID. So if you want to play a game of either I'm going to be asymptomatic or I'm going to be dead, and there's many, many variations of that in between. Some people are still having side effects of COVID. Their memory isn't back. They can't taste anything. People laugh and joke about it, but it's a serious thing that alters your life. So I always ask people, are you willing to take the risk that this could kill you? That's basically what we're talking about.
Speaking, just adding to that, there are people that have caught it, recovered.
Yeah, fine.
Recovered fine.
Right.
You know, they're back to running around doing the things that they normally do. I also have those who have caught it, and a year and a half, 9 months, 16 months later, are unable to get out of bed without feeling so short of breath that they have to stop every 3 to 5 feet to rest so they can get up and brush their teeth. I have people who are unable to work. They can't get back to their job because they're so short of breath that they can't do what they were getting paid to do prior to getting ill.
Right.
And that is something that's present not just in those that were so severely ill that they were hospitalized on the ventilator for 3 to 6 weeks. I have people that they had it, they were just home, you know, their primary care physician gave them some Decadron and said, take this for 10 days, and, you know, they're following up. And then they're still having a lot of symptoms, so they sent them in to see me in the office. And I have to have the discussion. Well, you had it. At this point, there's nothing medically we can do. You know, I can give you this, I can give you this, we can do this, we can do that. There's a certain amount of testing and working up that we want to do to just kind of evaluate, were you a smoker beforehand? You know, things that we need to do to kind of, you know, round out the evaluation. But basically, you know, if you felt great before you had it and you feel bad afterwards, you're looking at probably a 6 to 12 month recovery period if you get back to your baseline at all. If you're still having symptoms, you know, that far past the initial infection, it's likely it's going to continue. And that long haul COVID syndrome is no joke. The patients that I have that have it really wish they'd had, you know, done better as far as, you know, distancing, or are upset at the person that infected them that was an asymptomatic spreader that they caught it from. Because now they're left with a lifelong debilitating disease as far as we know. There's just still evidence is still accumulating on what's the recovery time, and no one knows.
And so that's different for everyone who's had it as well.
Yep.
Some people recover.
Yeah, some people recovered very quickly, and some have still not recovered.
And then when you talk about, again, the me mentality, now your life is changed, right? When you could have simply been more careful, listen to the science, get vaccinated, and you would have been doing just fine. Now you're out of work. You can't enjoy yourself. You can't go places. You can't travel.
Do you think some of that is psychological as well, like from what they endured or encountered while they had it?
Which part?
Be like, sometimes I just can't breathe, or just thinking, or is it definitely just all side effects of?
I don't think that a lot of it's not anxiety or psychosomatic. I don't believe a lot of it is psychosomatic. I have had some who are more short of breath, and some of it is anxiety, but I'd say that is the minority. A lot of the people that I have that have had these prolonged symptoms show evidence of abnormalities on lung function testing. Some of them have persistent scarring of the lung that occurred, because what happens in some patients, they develop a condition called ARDS, an acute respiratory distress syndrome, and it basically causes fibrosis of the lung because of the inflammation that occurs, and that doesn't go away. There are some people, even earlier studies, I believe out of Italy and China, have shown a permanent 20 to 30% loss of lung function. Permanent. It's gone. It ain't coming back. That's a lot. A significant loss of your normal function.
And then if you couple that, we see people who have heart dysfunction. You end up getting heart failure after this. So now you have pulmonary fibrosis and you have heart failure, I mean, your life has changed markedly, and that's not even talking about the financial obligation to treat these disease processes, to at least have you maintain something to where you're not just completely down the tubes.
So, cost, it's going to vary based on, insurance,
Of course,
what they allow. But
right.
Just throw kind of a round out. If me, like I said, I'm a pulmonary critical care doc. If you're seeing me, you are not doing well. Okay, there's concern, and you're going to need some long-term care. Average, particularly my hospital, the ones that live, you're on the vent about 4-5 weeks, on the ventilator, 4 to 5 weeks. That's on top of the sometimes 2 weeks that you were in the hospital prior to being on the ventilator, where we were trying to manage you on non-invasive means. So you're looking at, that's a month and a half in the hospital. And if you lived to that point, you're more than likely going to be going to another hospital for another, 6, 12, weeks for recovery.
Or step down,
sometimes to get off of the ventilator, if you can.
So it's a huge financial impact.
Yes. Because you can't work during the time that you're hospitalized, obviously. And, if an ICU bed averages, $5,000 to $12,000 a day, depending on where you're at, the costs can add up. You can easily hit $1 million in care. And that's just the bed. Doesn't include nursing care, doesn't include meds, does not include the physicians that are managing your care, doesn't include facility fees because you're in the hospital, procedures that may have to be done. There's a lot of things that go into that you may just not truly grasp because obviously you're not in the hospital, so you don't think about it. But these are things that occur.
Some myth busters then, as it pertains to the vaccine. What are some things that you guys have heard, and we're going to wrap it up right here, but some things that you guys have heard that are just absolutely ridiculous as it pertains to the vaccine, and why people are not getting them?
Several of the things that I've heard. I'll just lead with one. That babies are dead babies are in the vaccine.
Wow, I've never heard that.
Yeah, I've heard that people don't want to get it because dead babies are used, or fetal tissue is used in the vaccine. It's a very nuanced question, and one born partly out of truth, but also not true. So I'd say in the 70s, 80s, there had been fetus, so children that had died and their bodies were donated, to science or whatnot. And the early tissue from a developing fetus is called a stem cell. Stem because they have the ability to specialize into all the different cells in the body. The importance of these types of cells are that they are generated from a human. Vaccines are designed to induce an immune response and get the immune system to recognize something that's abnormal and to subsequently help your body to generate a response to that. And in doing so, you have to have human tissue to help induce a good, long-lasting immune response. So some of this, the cell lines from these tissues are probably still in production. And if you think about Henrietta Lacks, she has, there's cell lines that were, Henrietta Lacks is an African-American woman who had cervical cancer.
Yeah, cervical cancer.
And the importance of her disease is that the cells she produced continue to grow. They just reproduce, and they utilize that tissue in a lot of cellular biology because it's so reproducible and they grow. Now, this is at the Johns Hopkins University, and recently there have been changes where they've given honor to the family for the unethical way that her cells were taken and used for science without any remuneration or even acknowledgement, literally, for the contribution that she's had. So taking that a step back, those cells being used allow the researchers to generate a good response from the vaccines that are used. So while it's used in that theoretical component, the vaccine does not include dead baby cells.
Very misleading.
Very misleading, which is why I say to a degree, but a lot of these people are abortion, people, and they're like, but they don't recognize that, there's more to it. And people who donate their unborn fetuses didn't necessarily have an abortion. Sometimes you have a stillbirth or early placental death, early fetal death, and the liver, and those tissues can still be used for research purposes.
Dr. Goodlow, do you have any myths that you've heard or that you?
I've heard several. I have heard the one about the chip being implanted. This is what I say, and it's really piggybacking on what Dr. Lott was talking about. I always tell my students, my patients, anybody I speak to, you have to have a credible source. I can go on the internet and make anything true, right? I can make anything I want to be true and find someone to support what I say. We're talking about credible sources. For example, I'm in cardiology, American College of Cardiology. I'm forever citing things for best patient outcomes when I'm trying to titrate hypertension or do something like that. American Heart Association, even the American Diabetic Association. There's many medical journals that we base decisions off of. It's not just Googling, are there dead babies in this vaccine? Like, that's not, you have to come from science. Both of us having a science background, we're basing all decisions on science. So I would ask that you look at the CDC. You look at actual medical journals and look at studies. Do you know the difference between a retrospective study versus a systematic review versus a randomized trial? These are all things that matter when we talk about progression and trying to get vaccines out there and best patient outcomes and the outcome data that we've both been speaking about. So I'm really big on sources. Check your sources. If they're not credible, I dismiss it. It's just as simple as that.
If a patient comes to me and says, I saw this dude on Facebook that said this.
Right.
No. Ooh, I saw this website, something, www.iknowtheanswer.com. No. Show me what you got. I feel confident in my knowledge base to, either educate, and I have people that have what I'd say are credible concerns about, the vaccine. In which case, like I said, I have the discussion because I think it's important to talk. I don't just dismiss people out of hand unless you give me reason to. But I don't just dismiss people out of hand. I'll listen and talk with you about, your thoughts and provide evidence, education, and if you're interested, we can certainly talk about ways to help. But if you're going to refuse, please make it out of truth and not just,
Conjecture.
It's just, okay, if it's just what you want to do, that's fine. You have the choice to make your own decision.
Right.
That being said, if you decide you don't want to get vaccinated and you get sick enough to get hospitalized, where's your source that says it's not necessary? Go talk to whoever it is that told you that you'll live,
Right.
and tell them to, find a way to treat you. I still will, because my oath is to help those that are in need, and I'll do that. I have for the last years and will continue to until, such time as God calls me home and I'm no longer practicing. But until such time, I will do what I need to do. But, please do what you need to do. Please get vaccinated.
Listen, I cannot thank you guys enough. I think that it is important to have these kind of conversations to kind of increase awareness amongst ourselves and in the community. So I thank you guys for being willing to participate and share your knowledge with others. That's basically all this is a platform for us to just have conversations, especially when I have people like you that are as knowledgeable as you, to put it out there, whether it's 5 people listening or watching or 100, 200. I wanted to provide the platform for people to get the information from the experts and the knowledgeable people as yourselves. So Dr. G, the NP, and Dr. Lott, I thank you so much for your time.
Thank you for having us.
Thank you.
Thank you guys for joining us on the patio. We'll see you next time on Patio Parle.